Neurology Quiz number 103. Describe the pathogenesis, clinical features, investigation and treatment of metachromatic leukodystrophy or MLD. MLD is a rare autosomal recessive lysosomal storage disease caused by pathogenic mutations in the ARSA gene. This results in deficiency of the enzyme aryl sulfatase A. Aryl sulfatase A deficiency causes accumulation of sulfatides in the peripheral and central nervous system, especially in myelin, eventually leading to myelin breakdown or leukodystrophy. Sulfatides can also accumulate outside the nervous system, especially in the gallbladder and kidneys. MLD is of three main types depending upon the age of onset: late infantile, juvenile, and adult. This picture shows brown metachromatically stained myelin breakdown products in subcortical white matter on the left and peripheral nerve on the right. Accumulated sulfatides interact strongly with stains such as chrysal violet, resulting in a shift in the color of the stained tissue to golden brown. This phenomenon is labeled as metachromasia, from which the disease gets its name. Late infantile accounts for more than 50 to 60% of cases. Age of onset, first 30 months of life. Typically, early milestones are met, followed by progressive regression of motor skills, ataxia, dysarthria, spasticity, and hyperreflexia, as well as optic atrophy. Earlier onset is associated with more rapid progression of disease. Juvenile constitutes 20 to 40% of cases. Onset is between 30 months and puberty. Early milestones are met, followed by intellectual decline such as decline in school performance, behavioral difficulties and personality changes, psychomotor regression. Seizures can also occur. Clinical examination shows evidence of upper motor neuron signs such as spasticity and extensor plantars, coexisting signs of peripheral neuropathy such as hyporeflexia, and optic atrophy is also seen. Adult comprises approximately 10 to 20% of cases. Onset is in late adolescence through adulthood. It is characterized by slow progression of neuropsychiatric symptoms. Manifestations include problems in school or job performance, personality changes, emotional ability, and psychosis. In some patients, neurological symptoms such as weakness, spasticity, ataxia, or seizures may predominate initially. Associated peripheral neuropathy is also common. This picture shows loss of myelin in the occipital lobe on the left and in the pons and cerebellum on the right. The occipital lobe shows relative sparing of subcortical U fibers. Investigations, lab tests, aryl sulfatase A enzyme activity in leukocytes or cultured skin fibroblasts is decreased. Values range from undetectable to less than 10% of normal. Some individuals may have aryl sulfatase activity that is 5 to 20% of normal without any clinical manifestations. This is called aryl sulfatase A pseudodeficiency. Urinary sulfatides are increased. Diagnosis confirmed by molecular confirmation of pathogenic variants in the ARSA gene. Brain MRI. Areas of T2 signal hyperintensity are initially found in the frontal and parietal or the parieto-occipital periventricular regions and are hypointense on T1 weighted images. This appearance and location is characteristic but not specific. However, MRI can be normal early in the course of the disease. Later, these changes spread to involve the subcortical white matter with a tigroid pattern. EMG and nerve conduction study can show evidence for a demyelinating neuropathy. CSF examination is usually not required but can show elevated protein. Nerve biopsy is usually not required for the diagnosis but may show metachromatic lipid deposits. This is brain MRI from a patient with MLD. The FLAIR sequence shows periventricular hyperintensity, while the T2 weighted images show widespread involvement of the subcortical white matter. This is another MRI from a patient with MLD. The T2 weighted image shows bilateral confluent areas of high signal intensity in the periventricular white matter. Note the classic sparing of the subcortical U fibers as indicated by the arrowheads. Lesions are typically non-enhancing. These are MRIs from patient with MLD. T2 weighted MR images show numerous linear tubular structures with low signal intensity in a radiating or tigroid pattern within the demyelinating deep white matter. This appearance is characteristic of the disease. Treatment targeted therapy. This can be achieved through ex vivo gene therapy. This is a medical technique where cells are taken from a patient, genetically modified outside the body, and then returned to the patient. Patients receive an infusion of autologous hematopoietic stem cells transduced with a lentiviral vector encoding ARSA. It is now commercially available as etidarsogene autotem-cel or MLD and can treat primary CNS manifestations of MLD. It has been approved in the United States, United Kingdom, and Europe for individuals with pre-symptomatic late infantile and pre-symptomatic or symptomatic juvenile MLD. Before approval of gene therapy, bone marrow transplantation was the only option, though evidence for this procedure was mixed. This figure shows the principle of ex vivo transplantation, in which cells taken from a patient are genetically modified outside the body and then returned to the patient. Supportive care. This includes PT-OT to avoid contractures and falls and maintain mobility, feeding therapy as well as gastrostomy tube placement if needed. Medications that can be used include anti-seizure medications in patients with seizures, baclofen and Botox for spasticity, gabapentin and pregabalin for pain, antidepressants and antipsychotic medications for behavioral and psychiatric manifestations. Gallbladder involvement requires long-term monitoring as it may be associated with carcinoma.